Imagine having diarrhea again and again, abdominal pain, blood and stool, weight loss, and the shocking part is your own immune system is responsible for damaging your intestine. This condition is called as inflammatory bowel disease or IBD. And in today's video, we'll understand the complete topic step by step. Let's begin. IBD mainly includes ulcerative colitis and Crohn's disease. Both are chronic inflammatory diseases of the GI tract, but they differ in location, pattern, depth of inflammation, complication, and management. Let's start with the definition of inflammatory bowel disease. IBD refers to chronic, relapsing, remitting inflammatory disorders of the GI tract resulting from an inappropriate immune response in genetically susceptible individuals. In simple words, the immune system reacts abnormally against the intestine and causes long term inflammation. Now, coming to the epidemiology, around 3 to 7 million people are affected. The disease commonly shows a bimodal age distribution, first peak between 15 to 30 years, second between 50 to 70 years. IBD affects males and females equally. It is more commonly in urbanized and industrialized countries. Now, why does the disease occur? There are multiple factors contributing: genetic susceptibility, environmental triggers like diet, smoking, hygiene, medication, along with altered gut microbiota. So, the key concept to remembering IBD is that it results from a complex interaction between the genes, immune system, environmental factors, and gut microbiota. Now, let's understand the etiology and the pathophysiology of IBD. The etiology is multifactorial. First factor is genetic susceptibility. Genes like NOD2, ATG16L1, and IL23R. Second, environmental factors, smoking, Western diet, antibiotics, NSAIDs, etc. Third, defective epithelial barrier. In IBD, the intestinal permeability increases, allowing luminal antigens to cross the mucosal barrier. Fourth, immune dysregulation. There is abnormal activation of innate and adaptive immune responses. And finally, altered gut microbiota, also called as dysbiosis. There is a reduced bacterial diversity and loss of protective species. Now, coming to the pathophysiology, luminal antigens from the intestinal microbiota activate immune cells like dendritic cells and macrophages in the lamina propria. This leads to exaggerated release of pro-inflammatory cytokines. T helper cell pathways become activated. Th1 cells produce interferon gamma, while Th17 cells produce IL-17, IL-22, ultimately leads to chronic inflammation and tissue injury, causing persistent inflammation, ulceration, fibrosis, strictures, fistulas, and abscesses. Now let's discuss the clinical features. The common intestinal symptoms include diarrhea, rectal bleeding, abdominal pain, weight loss, fatigue, malaise, and fever. Systemic or constitutional symptoms include weight loss, low grade fever, fatigue, weakness, anorexia, anemia, growth retardation. One important point to remember is that symptoms may be relapsing and remitting. Also, severity does not always correlate with the disease extent. Now, coming to the extraintestinal manifestations, IBD can affect multiple organs beyond the gut. Musculoskeletal manifestations like arthritis, sacroiliitis, ocular like uveitis, episcleritis, dermatological like erythema nodosum, hepatobiliary like primary sclerosing cholangitis, hematological include anemia, renal like kidney stones, cardiopulmonary and other systemic manifestations also occur. Now comes the most important comparison: ulcerative colitis versus Crohn's disease. Let's understand this step by step. First, the location. Ulcerative colitis affects the colon only and the rectum is always involved. In Crohn's, it can be any part of GIT from mouth to the anus. Second, the distribution. Ulcerative colitis shows continuous inflammation, whereas Crohn's shows skip lesions with normal bowel present between diseased segments. Third, pattern of inflammation. Ulcerative colitis is superficial and mainly involves mucosa and submucosa. Crohn's disease is transmural, involving all layers of the bowel wall. Fourth, ulcers. Deep ulcers are characteristic of Crohn's. Fifth, rectal involvement. It is more in UC but may or may not occur in Crohn's. Granulomas are rare in UC but may be present in Crohn's. Now, coming to the complications, UC commonly causes toxic megacolon and increased colonic cancer risk. Crohn's commonly causes strictures, fistulas, abscesses, perforation, and malabsorption. Proctocolectomy is curative in UC, but surgery is not curative in Crohn's because recurrence is common. On imaging, UC may show loss of ostra, a lead pipe colon appearance. Crohn's may show cobblestone appearance, string signs, fistulas, and abscess formation. Now, some easy mnemonic. UC, ulcerative colitis. So we have colon, continuous, and colon cancer risk. Whereas in Crohn's, it can affect any part. Patchy skip lesions and complications are common and surgery is not curative. Now let's discuss the investigations and the diagnosis. Diagnosis begins with clinical suspicion based on symptoms, family history, and extraintestinal manifestations. Lab investigations include CBC, CRP, ESR, electrolytes, LFT, and nutritional profile. Patients may show anemia, leukocytosis, elevated inflammatory markers, and nutritional deficiencies. Stool investigations include stool culture. Fecal calprotectin is especially useful because it indicates intestinal inflammation. Now, the gold standard investigation is definitely colonoscopy with biopsy. Colonoscopy helps to assess the disease extent, severity, and activity. Histology confirms the diagnosis and assesses chronicity and dysplasia. Imaging studies include MR enterography, CT enterography, and ultrasound. These are useful for assessing bowel wall involvement and complication. Now let's finish with some rapid high-yield examples. The string sign of Kantor on barium studies suggests Crohn's disease stricture. Primary sclerosing cholangitis with IBD strongly suggests ulcerative colitis. The combination of fistula, skip lesions, granuloma always points towards Crohn's disease. Continuous colonic inflammation always suggests ulcerative colitis. Smoking worsens Crohn's but is protective in ulcerative colitis. So, what are the common MCQ traps? Thinking granulomas are always present in Crohn's? No, only 50% of time they are present. Confusing toxic megacolon. It is more common in UC and not in Crohn's. Assuming surgery cures Crohn's disease? No, because there is high recurrence. Forgetting rectal sparing in Crohn's versus always involved in ulcerative colitis. Watch for perianal fistula. It is pathognomic for Crohn's disease. Now, Viva questions to master. How do you differentiate ulcerative colitis from Crohn's on colonoscopy? So, ulcerative colitis shows continuous inflammation beginning from the rectum, while Crohn's shows skip lesions giving a cobblestone appearance. Next, what are indications of surgery in IBD? So, whenever medical therapy is not working, whenever there are more complications, we have to go ahead with a surgery. Naming the extraintestinal manifestations, uveitis, the joint complaints like sacroiliitis, these all things you can name. What is the role of fecal calprotectin in diagnosis? It helps to detect intestinal inflammation and differentiate IBD from IBS. Explain the smoking paradox in IBD. So as we know, it worsens Crohn's, but in ulcerative colitis, the patients feel better. So that was inflammatory bowel disease simplified completely. If this video has helped you, do not forget to like, subscribe and share. See you in the next video.